Hey everybody, welcome to Regulatory Joe. I'm Joe Boyle, the President of Regulatory Solutions here at Penstock. And today, I'm very excited to introduce our special guest and also very own Director of Plan Management, Bryan Connole. Bryan, tell us a little bit about yourself.
Thanks, Joe. Happy to be here. I've been in the insurance field for about 7 to 8 years now, initially starting off as a territory manager, and where I was working on product implementation for many states in the smaller group, ACA, as well as large group space. I was doing that for a few years, and then an opportunity actually opened up in the regulatory space within my company, and I jumped on that opportunity to learn more beyond the product implementation piece and grow my career, take another step in my career. It's something I wasn't sure what I enjoyed, but I do. It's something that I definitely have grown into, definitely enjoyed learning all about the ACA, the regulatory filing, working with state departments of insurance, working with CMS around, the rules and regulations, and trying to improve the processes around the QHP certification and filing piece in general. And that kind of led me here over to Penstock, where we have partnered up and, hoping to, again, continue to improve the process around QHP certification and regulatory filing and helping clients in states, in that space who need assistance.
Yeah, so Bryan, it's easy for me to forget all the years we've worked together, and glad to have you here on the team. It's really interesting because with all the complexities in the ACA landscape and the strengthening of both federal and state policy, specifically for plan year 2026, we're up against a lot for this year. What are some of the hot topics, if not the biggest hot topic, that you're looking forward to tackling for this year?
One of the big topics we've noticed is prior authorization for drugs in the formularies going forward. And so we did notice multiple objections for plan year 2025, where states and CMS came back and asked issuers to remove prior authorization for multiple drugs, one being your PrEP formularies, because, again, that's not in compliance with several of the rules and regulations going forward. So I think that is a key topic to keep an eye on going forward this year, and actually making sure that, issuers are reviewing the state guidelines around prior authorization, as well as any rules and regulations being released from CMS, from the federal government, to make sure they are in compliance with those statutes.
That's great, Bryan. I understand, working with issuers, both small and large, through the last plan year, prior authorization was a big issue. I think that's a good lesson learned, especially as it relates to working with state divisions of insurance. We're seeing increasing strength with needs for justification forms to be attached to the templates to justify noncompliance for certain issuers. What else are you seeing in working with your clients that you could share with us that other folks may find beneficial?
Exactly. I do agree with you on the justification forms. One other area we are seeing is with the adverse tiering tool. And so we definitely want to make sure issuers are running that tool on their prescription drug template prior to submitting the template in their binders and to CMS. You want it to be as accurate as possible and avoid any objections that may come up. So once you run that tool, and if anything comes back where you need an adverse tiering justification form, you want to make sure that you fill that out and submit that along with your prescription drug template when you are submitting into the binder into CMS to avoid any objections coming back from the state or the federal government.
That's great, Bryan. And from a best practice perspective, I acknowledge and recognize and just want to call out how labor intensive it could be for certain issuers to run these tools and functions and to produce the outputs. There's multiple iterations. It's almost impossible to run the tool and get a clean result output on the first try. Would encourage issuers to also create change governance or a change control process to track the versioning of their template outputs to make sure that they're having the most clean submission possible. I also wanted to call out, and I think in working with CMS, we've noticed that there are other certain tools and instructions issuers can leverage, such as the RegTap QHP webinars that are just starting now by CMS, where folks can log in and listen to certain sessions put on by panelists about the best way to run tools, FAQs, and other.
Exactly, Joe. So definitely want to take advantage of those RegTap webinars, especially when you're creating the prescription drug template. You want to make sure you're attending that webinar that focuses specifically on that one template. A lot of times they'll do the demo on there so you can see live, to make sure you're filling it out correctly. And there's always a chance for Q&A. In addition to the advanced, tiering tool, there's also the drug count tool in the Formulary Review Suite. So again, those are two other options you can use. My advice is to run as many tools as possible. Make sure that it's accurate as possible, just to avoid, again, any objections, any concerns as you submit the templates in the binders going forward. Run as many tools as you can. And then if needed, always submit those justification forms for any instances where you have an outlier or you have a result from either any of those tools.
That's a really good point, and I almost forgot that too, because with the Formulary Output Suite and the Drug Count tool, those are 3 codified tools that issuers should be running. It's interesting because working with different health plans, I know based on how the org design of a department is, you could have the pharmacy team running the tools on the plans and products, or you could be having the product team running the tools on the plans and the products. If you don't have any, develop strong relationships with your stakeholders internally, with your pharmacy team, or even, in fact, the PBM behind the pharmacy or formulary benefits, because health plans who are reliant on their PBM to give them their RxQEs, to give them their retail or mail order supply for tab 1 or tab 2 on the template, could create a bottleneck between creating justification forms, asking for new data, and running the tools.
That's true, Joe. Very true. Definitely you want to communicate because, again, a lot of issuers, you do have separate departments who are working on separate templates. And so sometimes you have that pharmacy area that is working specifically on the pharmacy benefit template. In my previous experience, I had a pharmacy team that ran the pharmacy template and kind of handed it off to us, and it was just our job to go ahead and submit it. And so you definitely want to have that strong communication. If it's an internal team, definitely have that communication with them to make sure that you're in agreement, what is going on with the template, both the tabs, and if there are any issues, you're having that clear communication as to what the issue might be. And then again, some issuers also have, an outside PBM they're working with as well. So again, clear communication with them to make sure that you understand everything that they're populating on that template. That PBM or that pharmacy team may be running the template, but maybe you run it again yourself. So maybe you both run it. CMS right now has MPMS where you run the plan validation, and sometimes issuers might think, I'll run MPMS, the prescription drug template will come back accurate within there, and then they'll kind of move forward. I think it's always a good practice to, beyond just running that plan validation, take a few minutes to run those, separate review tools outside of MPMS. It's only going to help you. It's only going to help you to avoid objections or any issues going forward. So again, outside of MPMS, take the time to run those outside tools. And then again, communication with your pharmacy team or outside PBM is definitely critical to making sure that you're both on the same page and everything on that template is as accurate as possible.
Awesome. And I couldn't have said it better myself too, because so in order from A to Z, adverse tiering, drug count tool, formulary review suite, those are the three that are going to set you up for success for MPMS validation. Now, I also recall, if I'm not mistaken, that validation in MPMS is one thing, but where issuers also encountered significant issues in rework, almost missing federal deadlines, was during cross-validation. So you can validate a template in MPMS all day long, including the pharmacy template, but once that cross-validation occurs and you're comparing the pharmacy template against the PBT, against the rate data template, against all of these other, including business rules, that's where some unknown errors could come back that impact more than just one stakeholder, more than your pharmacy stakeholder. So had you encountered any of that during cross-validation or any best practices for issuers, maybe doing it for the first time?
You definitely want to do cross-validation. And in the cross-validation, that happens within the Formulary Review Suite tool. But then again, when you're running it through MPMS, you run the initial validation. When you're always required to run the cross-validation in MPMS as well, where it's going to run, in addition to the prescription drug template, it's going to cross-validate all templates within that plan certification. Even if the prescription drug template is accurate, you may be, I'm good to go, but then you run that cross-validation and then you're encountering an error within the PBT. The PBT does not agree with, the prescription drug template, and there's an area where you need to go ahead and fix. Always want to make sure you're running that cross-validation and make sure all those templates are agreeing. So yeah, that's definitely a good point, Joe.
Awesome. And that's also going to take care with consideration to the formulary mapping. So for issuers also who are mapping different formulary IDs to parent IDs, have to be mindful of that. Do you have a 2-tier formulary, 3-tier, 4-tier? We've worked with carriers that have up to 6+ tiers of prescription drugs through a generic, brand, preferred, or specialty across the board, so it can get complex. Also, wouldn't probably be a bad use of issuers' time to work with your product strategy team to make sure your product strategists are developing the plan designs appropriately, because all the decisions made up here or up at the beginning by leadership are going to cascade downstream and could cause a rework or abrasion.
Definitely, yes. No, you definitely want to work with your product strategist. And to your point too, yes, we've had, multiple clients where they've had 6 or 7 tiers within their formulary, up to 13, 14, 15, formulary IDs, which when you're translating that over to the plan and benefit template, you want to make sure you're lining up the correct formulary ID with the correct plan on the correct tab. It's obviously very detail oriented, but those are 2 pieces where you want to make sure everything's lining up correctly with the templates. And then, yeah, you want to have that communication with the strategy team to make sure what they are proposing. But you definitely want to make sure that you're up to date, you're following along with the new laws and regulations that are being passed by the states and by the federal government going forward. Sometimes, laws are passed after you have gone ahead and submitted your prescription drug template. I had an example of that just this past year where one state came back after we had submitted, and due to a prior authorization for the prep formularies, we actually had to go back after we submitted. So definitely always want to make sure that you're keeping up to date on that. You never know when the state is going to come back, or the government may come back and ask you to go ahead and fix that template. And if you can, formulate a way to make sure that you're having someone on your team regularly checking to make sure, check on those federal regulations, state regulations.
So this has been a great discussion, Bryan. And, when I pick up my proverbial crystal ball and when we look into the future, calendar year 2025, plan year 2026, even let's skip ahead to 2027, what do you see the future of the prescription drug template or even, frankly, pharmacy regulations going?
That's a great question, Joe. Most issuers are aware, CMS has been moving a lot of things into MPMS lately, trying to automate and make things easier as far as submissions and validation. So, crystal ball, looking to the future as they continue to move more into MPMS. Like this year, I think they're moving in the URT into MPMS. I could see a scenario where, they start moving in validation tools, the Formulary Review Suite, the drug count tool, the diverse tiering tool. You want to make sure that you're keeping up on that to make sure you're in compliance as well. We've noticed lately too, there's a lot centered around, PBM licensure in each state. So they're kind of tightening that up and making things a little harder on the PBMs, something that you want to kind of keep an eye on. I don't envision, any major changes, any major rework coming to the prescription drug template, but there could be some tweaks here and there. Hopefully that kind of stays the course. But those are the kind of things I'm seeing going forward to kind of keep an eye on and best practices going forward.
That's definitely some valuable advice, and I think all our listeners will definitely appreciate it. Well, that's a wrap. Bryan, thank you for your time. Give us a like, give us a share, and we'll see you next time.